Hi, my name is Andrew Penn. I'm a clinical professor in the School of Nursing at UC San Francisco. I'm also a psychiatric nurse practitioner, and I'm excited to be teaching this first class in your psychopharmacology series, which you will have over 3 quarters in the postmaster's multi-campus program. This is your introduction to pharmacology and some considerations about what you should think about before you begin to prescribe a medication. And also, we'll talk at the end about pharmacokinetics. These are the objectives that are also in your syllabus, but really what I intend on doing over the next several quarters is really taking your prescribing practice to a level of sophistication and understanding that you will not only understand what medications are available now, but those medications which will come out in the future, that you'll be able to build upon the knowledge that you will leave this class with and be able to apply new technologies as they emerge to treating your patients. So this is what to consider before prescribing. I want to welcome you officially to Harry Potter's Spells and Potions class. And I joke about this, but really, when you think about prescribing, especially the way we used to do it with paper prescriptions, if you remember these, there was really it had a spell-like quality to it. We would use these sort of obscure abbreviations and these symbols, and we would hand this over on a piece of parchment paper, and it really felt like something very special. Now we just knock them into the computer and they go automatically to the pharmacy if we're lucky. But really, what I want you to leave this class feeling like is that you are becoming a nurse psychotherapist who also knows how to use medications. You'll notice I said psychotherapist first, and that's intentional because while pharmacology may be one of your primary roles as a psychiatric mental health nurse practitioner, it's not your only role. And we'll talk more about that in a moment. And there's really, I really do think that there is not only a science to understanding pharmacology, and we'll certainly spend a lot of time talking about that, how medications work on receptors and what happens inside the cell once those receptors are activated or blocked. But there's also this real art to what we do, and thinking about this as a kind of a craft and an art. That you will learn how to use these tools, but there's a way to use them artfully, and that's what I aspire to teach you. And what we're doing with psychopharmacology is we're really trying to use drugs to change the way the millions of cells that we have in our brain and our central nervous system, how they talk to each other and how they communicate inside of themselves. So not only intracellularly or inside the cell, but extracellularly between cells as well. And ideally, by doing that, we're going to be able to have some influence over things such as mood, thinking, and behavior. But it's more than that. It's also using this relationship that you're developing with the patient to help them get better in whatever way is going to work best for them. Medications may be part of that, but you may also be using things such as meditation or exercise or psychotherapy as part of that process. Now, for many of you, you have some awareness of psychiatric medications because as primary care providers, you've probably been prescribing them already. And so you're probably past this point where you didn't know how to do the thing at all. That's where we all were when we first started out. And then we got to this place where we knew there were things we didn't know how to do, and it kind of bugged us. And then we get to the place where we know how to do it, but we really have to think about it. And then eventually, hopefully, we get to the place where we can do the thing and it's really just second nature. It's almost automatic. Now, this also maps very nicely onto Patricia Benner's classic model for teaching nursing professionals, which is the model from beginner to expert. Now, most of you are probably somewhere around here, maybe a little more to the right if you've been working in a setting where you've had to do a lot of psychiatric prescribing, but you're aware that there are things that you don't know, and that's why you're here. That's why you are in this program because you want to fill in those lacunae. And by doing that, you'll move yourself more towards this place where you really just know what to do almost without having to think about it. Now, I often think about learning this way. I live in Northern California. As I'm recording this, it's springtime. It's beautiful and green for that little window of time that we have after the winter rains. And, I like to go out for hikes with my dog. And sometimes we see these big turkey vultures flying overhead. And I think, I watch these birds sometimes and I think, they go up and they follow these thermals of air, these big circles, spirals of air, and then fly higher and higher. And eventually, I think, do they ever look down and think, gosh, I thought I was going someplace. I thought I was going in a straight line, but it looks like I'm over the same spot again. How frustrating. And I think sometimes when we're learning something new, like something complicated, like pharmacology, it's easy to find ourselves feeling this way, thinking, gosh, I thought I understood this, but maybe I don't. And but I thought, well, what if that bird goes a few passes and it looks down and says, oh my gosh, I'm over that same barn again. But this time, instead of getting frustrated, it kind of looks left and right and it says, oh, huh, I never knew that the ocean was right over that hill, or I never knew that that road connected to the next town over. The point being that we start to see these sort of connections between things. Each pass as we go through, we go from beginner, advanced beginner, become proficient expert, and then we realize we don't know things still. And that's fine because we're going to go through that same pass. And each time we visit this material, we begin to connect these dots. And what we really begin to connect is the connection between things that we already know, but didn't know how they were connected. So what I'm hoping is that as you go through this class, you will feel that clicking sensation of when things come together that you kind of understood, but didn't really fully understand. And now you understand them better, or you understand them in a more deep way. And this is certainly something that I've experienced just as a teacher, is having to learn things in order to explain them. Things have finally made sense to me. So I hope to share some of that with you. Now, before we can begin to prescribe, we obviously need to know why we're prescribing. And the only way we can do that is to go through this process, which should look fairly familiar to you because this is how we lay out our notes. We can't just dive in and say, oh, somebody comes in and says, well, I feel kind of sad today. Well, you must have depression and you need an antidepressant. That's not enough information, obviously. We need to get that full history of the illness, knowing how it's impacted the person. We need to understand what they're trying to get to. We need to understand what treatments they've tried before and if they've helped or not, because we don't want to reinvent the wheel if we don't have to, and we don't want to do things that didn't work before. We want to know if something has helped a family member who has a similar condition. Obviously, we need to think about what other medical conditions do they have and what other medications are they using so that we can avoid drug-drug interactions or things that choices of our own prescribing that might exacerbate a ongoing problem. We also need to know what substances they use from a perspective of safety. And we need to get a snapshot of what that person looks like today. And then thinking about our diagnosis, because really our diagnosis, our treatment is only as good as our diagnosis. If our diagnosis is incomplete or vague, our treatment probably will be too. And then thinking about how do we get there. So with all that in place, we can then begin to think about prescribing. Now, one of the things that's really important to think about is that, we might be listening for symptoms and conditions and diagnoses, and we might get overly attached to a single symptom. We might hear somebody come in and say, well, I have these kind of mood swings. And then we start to listen preferentially for maybe symptoms of bipolar disorder. Now, that might turn out to be correct, but there's lots of things that can cause mood swings. So it's important that we don't get too caught up on thinking about our diagnosis too soon. And more importantly, our patients are probably less interested in diagnosis than they are in being seen and heard and understood. And if that serves to help them get to a better treatment, that's great. But we want to be careful not to overprivilege one or two single symptoms and miss the big picture. When we're thinking about diagnosis, I want to introduce you, if you're not familiar already, to the idea of Occam's razor. This is a logical tool which goes back centuries. As you can see, William of Ockham was a monk who lived a long time ago, and his basic idea was that when we're trying to explain something, the explanation which requires the fewest assumptions, or i.e., the simplest explanation, is often the correct one. If we have to jump through a lot of logical hoops and we say, well, if the person has this and this caused them to have that, and then that caused this, and that's why they have this diagnosis, it's probably incorrect. Another idea that we introduce here is something called Bayesian probability. Now, really, when we think about how do we diagnose a patient, we can never be 100% certain. We can have a reasonable suspicion of what we're treating. We can look for confirmation in that, but there's always a possibility it could be something else. So we usually go with the explanation which requires the fewest assumptions. We have an axiom for this when we say, when we hear hoofbeats, we think about horses. We don't think about zebras. In fact, we actually call very rare conditions in medicine zebras for that reason, because they're, as zebras are, uncommon. And so when we work with a patient over time, we're always thinking about how things are changing. So, for example, a patient may come in to see me, they're complaining of symptoms of depression, they have a history of depression, I diagnose them with depression, I start them on an antidepressant. A week later, they come back to me, they can't sleep, their mind is racing, they're talking a mile a minute. Suddenly, I have new information to feed into my model. So now I can look at this and say, oh, maybe this isn't major depression I'm dealing with. Maybe what I'm actually dealing with is bipolar disorder. So I've taken that new information, I've fed it into the calculus, and I've said, I think there's a higher probability that this condition that I'm treating is actually bipolar disorder. So I'm going to change my diagnosis and my treatment plan. And so we're always sort of juggling probabilities in our treatment. We can never be 100% certain. We can come closer, but we're never 100% certain. And sometimes, we're going to see some weird things, especially if you work in a tertiary care center where people come to get weird, rare things treated. It's going to give you an observational bias thinking that those rare things are more common than they actually are. So, here are things that look like horses that are actually zebras. Now, an important question that you're going to get asked by patients is, do I need to take medication? And that is going to be a subjective decision that you have to make with each patient. But here's some guidelines that have helped me over the years. One is really thinking about how impaired is this patient from their ability to function. So there are plenty of people who can have symptoms that are not terribly impaired by them. So that person might not need medication. Just the presence of a symptom does not necessarily necessitate a treatment. But if those symptoms are preventing the person from functioning in their essential roles, such as being a parent, going to work, being a student, then we might want to think about treatment. Additionally, everyone has a different threshold for intolerable suffering. Think about the last time you got a headache. How long did you wait before you thought, well, maybe this will go away? I'll wait to take something to help with the headache, and then eventually you get to the point where you say, ah, I'm just going to get some ibuprofen out of the medicine cabinet, or maybe you had a lingering cough that you were putting off going to see your healthcare provider about. There's a certain point at which we say, okay, I'm going to do this. And then finally, when the symptoms of the condition make it so that the person cannot avail themselves of other kinds of treatment. A classic example of this would be psychotherapy in a patient with severe depression or anxiety, getting those symptoms of depression or anxiety down a little bit so that the person can then avail themselves of psychotherapy might be a very useful favor to that patient. Now, we always want to think about whose anxiety are we treating in psychiatry? Now, I sometimes have joked with my residents before that in psychiatry, we're always treating anxiety. And sometimes it's actually the patients. But a lot of times it's a third party. It's a parent, it's anxiety around their child, it's a teacher's anxiety around a student, it's a spouse's anxiety around a loved one. And it's not to discount that concern, or it's our own anxiety about the patient. But we really need to ask ourselves, whose anxiety are we treating here? Are we treating the patient's anxiety, or are we treating another person's anxiety? Because sometimes we get caught up in this urgency that we have to do something when maybe we have a little more time than we think. Now, informed consent is one of these things, kind of like patient education, that is kind of often seen as like an afterthought. It's like some form that a patient signs before they start taking a medication. I want to invite you to think of it more deeply than that. It's not just a form that we get signed in a box that gets checked, but really it's this sort of secret force for improving trust between you and your patient. Because what informed consent really is, is a conversation about risks, benefits, and alternatives to treatment that we document, of course. But really, it's helping that patient feel safe with the treatment that you're providing them. And so, in order to do that, I think it's really important to talk about the most common side effects that a person is likely to have. And this is going to preserve your credibility. Because if you say to a patient, well, this treatment doesn't have any side effects, and they get a side effect, they're going to wonder what else you were not totally forthcoming with them about. And the other thing that we want to go over are things that are severe, even if they're very rare. A good example of this would be the use of, say, lamotrigine in Stevens-Johnson syndrome. Very severe, but very rare skin condition that can happen with that medication. And the reason for this is it's going to protect your liability. And so all of those things you want to document. The more specific you are, the more easy it is to defend those decisions should they ever be questioned in a malpractice suit or something like that. And informed consent isn't a one and done issue. It continues to evolve as the person is on treatments and if those side effects begin to emerge, you talk about those and you say, yeah, that could be a side effect of this medication. How do you feel about continuing on this medication given that? And you continue to have that informed consent conversation. Now, some people come out of this program saying, gosh, I don't feel like I know how to do psychotherapy. And I want to challenge that because a big force in psychotherapy, a big portion of the outcomes is actually not specific techniques like, say, CBT or IPT. It's the what are known as common factors in psychotherapy. And these are largely things such as the routine and ritual of the treatment. You come into the office on a certain day of the week, or you get on your computer and you have a telehealth visit in a certain way. And when you're having those appointments, there's a shared sense of intention and purpose and goals. There's things like warmth and empathy in there. And it's this feeling that we're collaborating on the same project. And this is an important part of psychotherapy, irrespective of what type of therapy you're doing. And a lot of times, what I find is that psychiatric nurse practitioners often discount how good they are at this. And they think, oh, because I haven't done thousands of hours of CBT training, I'm not a psychotherapist. And I want to challenge that because often these are the things that are most important in the outcome of psychotherapy. And some of that we could also think of as placebo effects. It's important to understand that the placebo is with us even when we are using an active drug. And what do I mean by that? So take a look at these two bars. So on the left, this dark blue bar, this would be, say, the hypothetical response of a antidepressant. And on the right there, we have the placebo response. So the response of people that got randomized to a blinded placebo. You'll see that a lot of them got better too. And in fact, if we superimpose that orange bar over the blue bar, we begin to see that the placebo effect is present even when we are using an active drug. Now, antidepressants are better than placebos, otherwise they wouldn't get FDA approved. But it's important to understand that the placebo response is far from zero. And in fact, when we look at this is a very interesting study done by a guy named Ted Kapuchik at Harvard, who does a lot of research, and he's actually trained as a traditional Chinese medicine doctor, and he does a lot of research on the placebo effect and also on acupuncture. And so this is an interesting study looking at treating IBS, irritable bowel syndrome, and you either got randomized to a wait list or you got just placebo acupuncture. Not exactly sure how one does placebo acupuncture, but you can read the paper if you want to read their methods. And so that middle group got placebo acupuncture, but just from kind of a cool, aloof, not super engaged person. But the person on the left, that group on the left, they got that same placebo acupuncture, but they got it from a nice, warm, attentive, confident person. And look who reported feeling better. The people who got the placebo acupuncture from that confident, warm, caring patient, provider rather. The placebo has lots of different inputs. One of the things that's particularly interesting, you can look this up if you want, is that you can actually reverse placebo anesthesia with naloxone. Now try that one on for size. So that means that there is an a activation of your endogenous opioid system when you are taking a placebo for a pain condition, and that can be reversed with the same drug that we use to reverse opioids, naloxone. But you'll see that a lot of these things that I highlighted in blue are really things that we can do as providers, as skillful providers, to amplify this placebo effect. So it's kind of interesting that we're starting out a pharmacology class talking about placebo effects, but it's important to understand that the placebo is really in the room no matter what we're doing. And if we take a look at these sort of factors, these behavioral factors, first of all, it begins with the patient asking for help. Now, think about last time you sought out medical care. You probably were thinking about it for a while before you decided to go ahead and reach out and make an appointment. So our patients have too. And so by the time they come to you, they're kind of already primed for feeling better. And then we engage in this sort of regular ritual of meeting on a regular basis, hopefully, and we have this agreement of what we're working on together and how we're going to go about that. We're doing this in a warm and caring way, which engenders trust. We're helping the patient understand what the problem is. Maybe we're giving it a name and we're explaining how we're going to treat it. And this begins to instill hope. There's an idea that things could be better, things could be different. In fact, we might even imagine how our life might be different. We can think of it like a multiplex theater, and in each theater is a different version of our future life. We can begin to imagine what that might look like. And then finally, we do this in this place that is sort of filled with these symbols of knowledge and skill. Think about, why do we put our diplomas on our walls of our office? I jokingly call them my receipts. But, I had a patient come into my office once. That's my old office on the left there. And he said, "Oh, you're a UC guy, I see." I think that was a positive thing for him. But the idea being that, these sort of symbols incur meaning, and that meaning goes into these common factors of therapy and placebo effects. Now, whatever medication we choose to go with, there are three hurdles that we have to get over in order to successfully treat a patient. The first one is a question of tolerability. So if somebody can't take a medication because every time they take it, they feel sick or they throw it up, that medication can't help. We usually figure that out pretty quickly. And then after a few weeks, depending on the condition, might even just be a few days, or maybe even a few hours, we begin to see if it's starting to help. So in an antidepressant, that might take 3 or 4 weeks. With a medication, a stimulant for ADHD, we might see that on the first day that we treat the patient. And then finally, after some playing around with the dose, usually, we try and get people into remission. And the goal here is to really reduce all symptoms to the point where they are no longer impairing function. We don't always succeed at this, but we want to make this our North Star. We want to try and point the treatment in this direction. We don't want to leave people sort of half-baked on low doses of medications that might be more effective if they were increased. Now, there are certain things that I have found over my 20 years of practice, that if you make people gain weight, if you make them lose their sexual function, you make them drowsy all day, they generally will stop their meds. And you can kind of understand why. I think most of us would probably do the same. So these are often deal breakers for many patients. And here's just some wisdom, again, coming from many years of practice. When I first started out, I thought that everybody needed to leave my office with a prescription. Otherwise, I had somehow failed. And the reality is that sometimes medications are not the right tool for the job. Maybe sometimes things like exercise or meditation or social engagement are actually more powerful tools, or psychotherapy. And the problem as a prescriber is that we're kind of walking around with a hammer, and then everything starts to look like a nail, and we start thinking, gee, what medication could I line this problem up with? Forgetting that maybe sometimes the best treatment might not be a medication. Now, similarly to what I just said about getting people from response into remission, we want to make sure that we get the job done, but we don't want to overshoot. You don't want somebody having excessive side effects because they're over medicated. And unfortunately, there's no way of getting around side effects. We can minimize them, we can deploy them thoughtfully. So for example, a patient who is having a hard time sleeping and also has depression, or maybe has also lost their appetite, a medication like mirtazapine, which is an antidepressant that tends to make people drowsy at night after they take it, and also tends to increase appetite, might be just the tool for the job. But that's an example of using side effects to our advantage. But there's no getting around side effects. If you ever have a provider tell you there's no side effects to a medication, you should probably run the other way because they're not being totally honest with you. Now, of course, the best medication in the world can't help you if it doesn't leave the bottle because they can't tolerate it. So we have to find medications that our patients can tolerate. And I'm always interested in engaging with patients in this decision-making process. So I tell patients, look, after we talk about what's going on with you, I'll give you some suggestions as to what I think might be going on and what we might be able to do about it. And you can think of this like a menu. And you can always decide you're not going to order off the menu. And that's always a choice there, but I'll try to give you at least a couple of different things that we could choose from. And if this medication works, the idea here is that you should feel more like yourself. You should feel normal. You shouldn't feel better than well. I've had patients ask me, if I take an antidepressant, am I going to be happy all the time? And I said, gosh, I hope not, because that's not really a normal state of being. We want to be able to visit happiness, but we don't usually spend all day there. So we want to be able to have that kind of emotional range that's restored when people feel normal again. And we're always thinking about plotting efficacy of a medication against the tolerability of that medication. So in an emergency, you use the most effective medication there is. And so I think this is why haloperidol, for example, remains a standby in many psychiatric emergency rooms, because when somebody is acutely psychotic, this is a medication which pretty reliably works. It's not very tolerable. It's not a medication you'd want to be on for a long period of time. It's a small handful of people who like it, but most people don't. On the other end of the spectrum might be a medication like buspirone, which I think of as largely a placebo. So very tolerable. I'm not sure how effective it is. And then most of our medications are scattered somewhere in the middle. I'd say paroxetine is less tolerable, reasonably effective. Lithium, somewhere in between, very effective though. Lamotrigine, maybe not as potent as lithium, but more tolerable. Now, medications aren't going to work for everything. So medications generally tend to treat symptoms. Now, the text that you're going to use for this book will somewhat disagree with me on this, and that's fine because unfortunately, in psychiatry, we don't have many what we might call disease-modifying drugs. Lithium might be one of the exceptions. Most of our medications are treating symptoms. And these are the symptoms on the left that we can generally treat with medications. And they're things that you're familiar with. Now, often we are asked to change the things on the right with medications. I don't, unfortunately, have a medication that makes people's lousy job better or their unhappy marriage. Now, if their depression is making it so they can't function at work or they can't function in their relationship, I might be able to help with that. And I might get secondary effects of improving, say, their relationship. But there's a lot of things that unfortunately medications just don't treat. And many of these things are systemic. Now, for example, if somebody's schizophrenia is making it so that they cannot maintain housing, then adequate treatment of schizophrenia will very likely help that person maintain housing. And so it's a little more complicated than just a yes or no, but it's just important to understand that medications can't do everything. In this class, I want to try and begin a convention here in the first week where we try and use generic names. I'm not going to make you use the chemical name of the drug, because that's pretty much unpronounceable. But say a medication like Prozac goes by many different names depending on where you are in the world. But all of them would refer to this as fluoxetine because that is the generic name. So I want to try and lean towards generic names. I realize sometimes they're a little harder to pronounce and they don't stick in your mind as easily as these brand names that a lot of money goes into choosing, but it is sort of the convention to use the generic names. And I also want to talk just briefly about how medications come to market. So on the left side here, it takes anywhere between 10 to 12 years to bring a molecule from its initial discovery all the way through clinical trials to FDA approval, commercialization, and release. And once the drug is discovered, usually it's patented. That patent lasts for 20 years, typically. And so when that drug comes to market after, say, 10 or 12 years of preliminary research, it only has 8 to 10 years of patent life left. And during that patent life, there's only one company that can make that drug, the people that patent it. After that patent expires, the drug goes generic and it can be made by multiple manufacturers, which generally drives the price down. So that's the difference between a branded or a patented drug and a generic or off-brand drug or a expired patent drug. But in this class, I would ask that in your correspondence and your writing, you generally lean towards using the generic names of drugs. I also want to talk briefly about enantiomers. So enantiomers sometimes get people's minds a little bit twisted. Doesn't need to be too complicated. So in chemistry, there can be two versions of the same molecule. And when there is such a thing, it's known as an enantiomer or stereoisomer. We can think of this as mirror images of each other. So if you think about your hands are not identical to each other. On this hand, my thumb is to the left. On this hand, my thumb is to the right. They're not identical. But if I hold them like this, they're mirror images of each other. If I try and put a left-handed glove on my right hand, it's not going to fit very well. And so similarly with molecules, so you can see in this one, the positioning of those molecules mirror each other, but on the one hand, you've got, say, a hydrogen molecule on the right, on the other, you've got the hydrogen molecule on your left. Now, when these two versions are mixed together into a drug, that's known as a racemate or a racemic mixture. And sometimes we just use one side of the drug. Sometimes we use a mixture. So for example, citalopram or Celexa is a combination of R-citalopram and S-citalopram put together in the same pill. Now you may have said escitalopram. Wait, I've heard that drug before, and you have. That's Lexapro or escitalopram. And so, as it turns out, with that particular drug, R-citalopram doesn't really contribute much to the antidepressant effect. What it seems to do is increase QT prolongation, especially in higher doses. The escitalopram doesn't seem to have that same effect on QT prolongation, but does most of the antidepressant effects. So out comes Celexa, citalopram in the 1990s, early 1990s, and reasonably good drug, but some of those side effects made it more challenging to use in higher doses. FDA actually put a warning on it not to use it above 40 milligrams, but it turns out escitalopram doesn't do that. So escitalopram, being Lexapro, tends to be kind of more favored, especially now since they're both generic and cheap. Another example would be ketamine. So ketamine, when it's often referred to, is racemic ketamine. It's R-ketamine and S-ketamine. However, S-ketamine packaged into a nasal spray is known as Spravato. So there are these different versions of drugs. So just think about racemic mixtures or enantiomers. And I'll try and refer to that when I'm talking about the drugs in later classes. Of course, you all know this, you're all practicing clinicians, but just being in this good habit of making sure that we're not making mistakes with our EHRs, making sure we've got the right drug, right dose, and all the right boxes checked. Just good practice to be in, of course. And when we're talking about medications, I want to encourage you to eliminate the term non-compliance from your vocabulary. It's kind of dated, and it really doesn't have a good patient-centered orientation. So I like to think about either adherence or medication interest. So when somebody feels like the benefit of the drug outweighs the costs of the drug, they'll probably be interested in that treatment. If the equation flips and the costs become greater than the perceived benefits, and you'll notice I keep saying perceived because if the patient doesn't perceive the benefit, then they may not have an interest in the drug, even though the practitioner or the family member may see great benefit. And we see this often and sadly, of course, with schizophrenia, where somebody has anosonia, which is the fancy name for the condition of not being able to assess your own problems very well. That's a feature of schizophrenia. So it makes it difficult for that person to appraise their own illness. So that person may see a lot of downsides to taking that medication because they might say, well, it makes me sleepy or it's made me gain weight. But they might not see a lot of benefit in it. Therefore, they're likely to lose interest in that medication. And so when I'm talking to patients about medication adherence or medication interest, here's there are some techniques that I use. One of them is something called shame attenuation. And by this, you say, it's not uncommon for people to miss medication doses. Or I might make a gentle assumption or follow that up with a gentle assumption. I say, how often would you say you forget to take your medication? Like 5 or 6 times a week? And they're like, oh gosh, no, like maybe 2 or 3. You'll get a more realistic kind of appraisal of how often they're losing or not losing, how often they're forgetting to take their medication. And then when we're talking about, do you want to stay on this medication? I might just ask that person, what do you think about staying on this? What do you like about it? What do you not like about it? And if they're having a hard time remembering to take medication, the things such as pill boxes or putting the medication near the coffee maker, and if it's a morning drug, putting it near your toothbrush, if it's a nighttime drug, can just be simple little visual prompts in order to help people remember to take the medication. I want to talk a little bit about how drugs come to market because, I think we often forget that this is a long, kind of drawn out process. As I mentioned, the patent process begins when the molecule is identified at usually, about 20 years before the patent expires. And then there has to be all these sort of steps that go into bringing a drug to market. So things such as preclinical animal studies for safety, and then phase 1 studies begin to figure out what is a reasonable dose of this drug and how quickly does it move through the body, something called pharmacokinetics that we'll talk about soon. And then you move into phase 2, which are small studies to see if the drug actually has an effect that you desire it to. If it turns out to have those effects, then you can move on to phase 3 studies. Typically, there have to be 2 large phase 3 studies that show an improvement over placebo, not over an existing medication, which is what a lot of people don't understand. Many people think, say, a new antidepressant must be better than Prozac. Not well, nobody makes the drug companies do that test. So a drug that comes out onto the market has been shown to be better than placebo, but not necessarily an existing drug. In fact, very rarely, if never, an existing drug. And then a drug becomes FDA approved and a label is created. And what that label says is what the drug can be used for, in which populations, and at what doses. It also lists things such as side effects. And I'm going to have you go through the label in your homework at the end of this assignment to start to look at pharmacokinetics of a drug. You may have heard the term off-label prescribing, which means that we use a drug for a condition that is not listed on the label. Now, this can be fairly common practice. There's one drug that many of you are probably familiar with from psychiatry called trazodone that we use for the treatment of insomnia. And that is actually originally labeled as an antidepressant medication. Wasn't terribly successful as an antidepressant, but it made people pretty drowsy even at low doses. So somebody realized that it could be used as a non-benzodiazepine hypnotic medication. So that's off-label prescribing and is generally considered okay if it's something that all of your peers do. So if it's a common practice, then usually it's considered reasonable and defensible. I also want to talk for a minute about some thinking about statistics in clinical practice. Now, I know many of us sort of will begin to dissociate, maybe even become catatonic when we hear the term statistics, but I want to just introduce this conceptually. I'm not going to get into numbers here, and I want to separate out 2 important concepts. One is the difference, one is what is statistical significance, and then I want to talk for a minute about what is clinical significance. So statistical significance, which is often represented by something called a p-value, P stands for probability, is a measurement that asks, did this difference between the 2 groups, between the drug group and the placebo-treated group, is the difference just by a chance? Is it just fluke? Or is it there actually a real difference there? Okay. And so that the p-value is so the convention is 0.05, meaning 5% or 1 in 20, that there's equal to or less than a 1 in 20 chance of this being just a fluke finding. Okay. Now, this is often trotted out by manufacturers of drugs as if it's really important. And of course, it is important in that you don't want that finding to be totally just by chance. But the FDA is not going to allow a drug onto market if it's not statistically significant difference. Okay. That 1 in 20 number is kind of an arbitrary cutoff, but it's just kind of become the convention. What's more interesting to us as clinicians is clinical significance. So the question here is there enough of a difference for you to see your patient improve as a result of treatment with this drug? And now there are several different metrics that are used in the literature. As you start to read journal articles, you'll notice some of these used frequently. One of which is the Cohen's d, and the Cohen's d, typically a 0.2 to 0.3 effect size, is fairly small. 0.8 and above is quite large. Odds ratio is a comparison between what is the odds of somebody getting better on placebo versus an active drug. And so if there's an odds ratio of 2, that means that there's twice the likelihood that the person is going to get better on the active drug than placebo. If it's less than 1, that means it actually favors placebo over the drug. And then another way of kind of crunching these numbers is something called number needed to treat. Now, what this tells you is the hypothetical idea is how many patients would you have to treat with this drug in order to get one finding that you're looking for, one outcome that you're looking for? And obviously, the smaller that number is, the better. There's a flip side way of calculating side effects here, which is called NNH, or number needed to harm. And so with a number needed to harm, it asks how many patients do you have to treat before you would see that one adverse outcome? And with that, in that situation, you want a larger NNH. Small NNT is favorable, and a large NNH. So with that, I'm going to stop, and then we'll move on to the next section, talking about pharmacokinetics.